I want to go on and start talking about osteoarthritis, which is probably the most common disease that we see in clinical practice. And here's the case. A 64-year-old man comes to you for evaluation of knee pain for many years. So right away you get a more chronic history here, but has recently worsened. He denies constitutional symptoms. He has mild pain involving the left second and third distal interphalangeal joints. So once you hear distal interphalangeal joints, right away think about osteoarthritis. I didn't say it's the diagnosis 100%, but definitely think about it because it's one of the diseases that usually involves the DIPs. He reports no morning stiffness. On examination you hear right knee crepitation, but no erythema or warmth. Laboratory testing is the SED rate is normal, the CBC is normal. So what we were looking for there is evidence of inflammation. We wanted to confirm that this patient didn't have any inflammation, and his SED rate is normal, right here, and his CBC shows no evidence of anemia of chronic disease. So here comes a guy with knee pain, right, and then two joints involved in the finger, so he's got oligoarticular asymmetric involvement. It's not inflammatory because we checked the labs and he didn't have any stiffness, right, and you hear crepitations over the knee. The diagnosis is osteoarthritis, right? So if you want to verify that, you could do an x-ray of the knee and verify that, but this patient has osteoarthritis, and you could go from this point on, whether you get a film or not, and start to treat the patient. You don't have to wait for the film. The diagnosis is pretty clear-cut, and you could make a confirmatory diagnosis with the x-ray, but you could start treating the patient. So what is osteoarthritis? I told you already, it's the most common joint disease that we see. The most common joint involved is the knee. The second most common joint is the base of the thumb. So some patients tell you, the base of my thumb hurts, especially if I type or I do work. This is a very common joint to be involved for osteoarthritis. And then after this, after the knee and the base of the thumb, then the small joints of the fingers are involved very commonly, especially the distal interphalangeal joints. Now, the hip is also involved commonly after the knee, after the base of the thumb, and that is probably the most disabling one. When you have hip involvement from osteoarthritis, it's probably the most disabling one. In terms of quality of life, this is the most disabling one when it's involved the hip. The target tissue for osteoarthritis is not the synovium, it's not the bone, it's the articular cartilage. Basically, the articular cartilage fails. That's what happens. So when you have failing of the articular cartilage for some reason or another, what happens is now there's the friction forces increase, right? The pressure increases in the joint, and now there's secondary remodeling of the bone. So the bone is kind of tries to repair itself, and then you develop hypertrophy. The hypertrophy that the bone develops, these are the osteophytes that you see, these remodeling beyond the joint, reparative efforts by the bone, osteophytes, and then more reparative efforts by the bone. So you see a difference, right, in from one side to the other in the joint. You see a change of spaces, unequal spaces, because the left side is remodeling, the right side is not remodeling that much. So you see a unequal space in the joint, and then the osteophytes. All these are reparative efforts by the bone, secondary remodeling. By definition, osteoarthritis is not inflammatory. If there's any evidence of inflammation on the exam, on the history, or the labs, you have to look for something else. There is a very rare form of inflammatory osteoarthritis. You don't need to know that for your boards. Be careful, because people talk about it all the time. It is very rare, and nobody makes the diagnosis unless they're rheumatologists. So you better be careful if they're giving you any evidence of inflammation on the boards. This is not osteoarthritis. Knee osteoarthritis is the leading cause of chronic disability, and this is because it's a very, very common involvement. So the quality of life of older patients is suppressed because of knee osteoarthritis. This is a major issue. The major risk factors for osteoarthritis is age, but age alone is not a causative factor. Be careful of that. As people age, they are more likely to develop osteoarthritis, but age alone is not a reason to have osteoarthritis. Women get it more commonly than men. People that are obese get it more commonly than people that have normal BMIs. They showed this in the Framingham study. Major joint trauma, people that tell you I played football a lot and had reparative stress and stuff like that, they are more likely to get this. So there's some reason that in predisposed people, especially if they have major joint trauma, reparative stress and stuff like that, they're more likely to develop osteoarthritis. So think about the major risk factors. They're not modifiable except for obesity. That's a modifiable risk factor, and that's one of the things you tell patients to, lose weight, to basically, prevent, disability from osteoarthritis. So it involves mostly the weight-bearing joints, right? The hip and the knee. I said the knee is the most common one involved. The hip is the most disabling one. And the small joints of the fingers, especially the DIPs and the PIPs, it's slowly progressive, and it's not curable. There is no cure for osteoarthritis. Joint pain increases with exercise and relieved by it. So the patient says, in the morning, I feel good, doc, and then I walk around all day or I do whatever I have to do around the house, and then my joints start to kill me because now it's the pressure. There's no cartilage there on the bone that causes the pain. Versus people with inflammatory arthropathy, where they tell you in the morning I feel very stiff and then I get better through the daytime. These patients, by night they're very exhausted. Their joints are killing them, so they're always taking frequent rests. Morning stiffness, by definition, this is not inflammatory. It's always less than 20 minutes. If you move the joint around, you hear a lot of crepitations. That's basically because there's no cartilage there. And by definition, there's no systemic manifestations of osteoarthritis. The erythrocyte sedimentation rate is normal and no evidence of chronic anemia at all. Now look at this. This is the right here. This is an osteophyte involving the distal interphalangeal joint, and this is sometimes referred to as a Heberdine's node. Now on the other side here, this here, an osteophyte involving the proximal interphalangeal joint is called a Bouchard's node. So osteophytes involving the proximal interphalangeal joints, Bouchard's, right? And then Heberdine's is the distal, so B before H. That's how you remember which is which. But bottom line, both of these, all they are is reparative effort by bone. Nothing more. They're osteophytes. That's all they are. So on the X-ray findings, the unequal joint space, the osteophytes that we talked about, the Bouchard's nodes that we just saw right now, and the Heberdine's nodes, and then sometimes they tell us about these cystic areas just below the bony surface, right? The cystic areas are sometimes referred to as subchondral cysts. The subchondral cysts, again, they are reparative effort by the bones. So the cartilage fails and the bone tries to repair itself, and what does it do? It causes unequal space. It causes the osteophytes, which are the Bouchard's and the Heberdine's nodes, and then the third part of that is the subchondral cysts. They try to also produce more bone in reparative efforts. So that's what we see. And look at this. Now this is the knee osteoarthritis. Now look at this. Look at the space here, right? The space here and here, totally unequal, right? That's the hallmark of osteoarthritis. And look at this now. Look at this. You see how the bone, is outside the joint here, right here, and a little bit here. You can't see it well here. This is a small osteophyte. These are osteophytes, and these are the reparative efforts by the bone. And maybe, I'm not sure if this is the X-ray or we're looking at this, maybe this could be a subchondral cyst in this area. So but forget about the subchondral cyst so much. I want you to know the two things that are pathognomonic for osteoarthritis of the x-ray, of the knee especially. That's what they're likely going to show us, is the unequal space. And when you look at this x-ray, that's the first thing that jumps out on me. And then look at the edges here to look for osteophytes, right here. Right? These things here, these are osteophytes, reparative efforts by bone again. So the treatment, well, there's two ways to approach this. Non-pharmacologic, which means I tell the patient to do weight loss, muscle strengthening exercises, wearing the right shoes, and stuff like that. Very, very important. Muscle strengthening exercises are very important because when you strengthen the muscle, you take pressure off the joints. They're very important, as tolerated. You don't tell the patient to do impact, running and stuff like that. They can't do that stuff. But muscle strengthening and to be active is very, very important in quality of life in these patients. And weight loss, we saw that what the relationship is with obesity and osteoarthritis, and we said weight loss is one of the first things you tell the patient to do. And then we go to the pharmacologic treatment. So number one on the list here, number one, and this should be the first medication you're going to try on this patient, is acetaminophen. Acetaminophen is number one, high doses of acetaminophen. Remember, this is not an inflammatory disease, so I don't have to use nonsteroidal anti-inflammatory medications, right? I could go with acetaminophen first. Now, the right way to dose it is around the clock. The patient has to take it around the clock and has to take high doses. How high? About 2 to 3 grams a day. It's okay, as long as the patient doesn't have liver disease. That's the way you dose it. So they take like 2 tablets of extra strength, acetaminophen, 2 to 3 times a day, around the clock, every day. Even if they don't have pain, they take it around the clock. That's the only way they could benefit from it. If you try that, you'll see that acetaminophen is as good as anything else as a first-line medication when compared to anything else. If that doesn't work, and commonly after we use acetaminophen for some time, maybe the patient now starts to complain, has worse osteoarthritis, we think about adding on nonsteroidals. So you use the acetaminophen maximum. If this doesn't work, you don't stop that. You add on low doses of nonsteroidals. And I say low doses because you don't need high doses, because you only use high doses when you need anti-inflammatory effect. So for example, if you have ibuprofen, 800 3 times a day, that's maximum dose. That's anti-inflammatory doses. I only use that in something like rheumatoid arthritis or lupus. But in this patient, I don't have inflammation, so all I want is analgesic effect. How do I dose NSAIDs? Low doses. Ibuprofen, 200 3 times a day. Maximum 400 3 times a day. Low doses because I don't need the anti-inflammatory effect. That's the 200 that you could buy over the counter. The 800 you can't, right? Because that's anti-inflammatory. So you add on nonsteroidals to that. If that doesn't work, and especially if a patient has single joint involvement like the knee, that's mostly bothering him, you add some stuff like capsaicin cream. Capsaicin cream is a great thing. You could even put this on before the NSAIDs and try that after acetaminophen. Capsaicin cream comes from chili peppers, and when you put it topically, it's a cream, you put it topically on the knee, it desensitizes all the nerves. So it kind of stings you first, and then the whole area feels numb. So it's great because there's no systemic absorption. It works wonders. It's a little bit expensive, but it works wonders, especially with people with big joint involvement. Now look at this. The rest of the stuff here, you're going to hear a lot about in the news, and you're going to read a lot in the newspaper, but none of these have been shown in prospective studies to benefit patients with osteoarthritis. So hyaluronic acid injections, glucosamine, chondroitin sulfate, none of these you should use as first-line drugs, and they haven't been shown to benefit patients across the board with osteoarthritis. So they're not going to be in your Treatment profile. I say it again. You are not going to be asked to use these medications. If you're using them, you're probably making a mistake. If a patient is taking all the acetaminophen they can take, the NSAIDs, the capsaicin cream, and they still have disability, what do you do to these patients? You send them for joint arthroplasty. Remove their joint, give them a new joint. Joint washing, joint injections, they don't do anything. Only arthroplasty benefits patients that have severe disease. Severe disease means correlate with symptoms only, not radiographic findings. So if this guy tells me I can't walk across the room because you know, my joint is killing me and I'm taking maximum dose of everything like you tell me, I'm going to send this guy to the orthopedic specialist to get the joint replaced.